So the question is, discuss the effects of pregnancy on the respiratory system that are relevant to the practice of anesthesia. Include in your answers how these affect the influence and conduct of anesthesia. The best way to answer this question is, or any respiratory question for that matter, is A, B, C, and D. So A, what do we have? Anatomy. And also pre-oxygenation, oxygen reserve, if relevant. B, I'd talk about lung volumes. When you're talking about fever, you can talk about bronchodilation for B. That's mainly like FRC, that kind of stuff. For C, there's three C's: chemoreceptors. So that's talking about obviously the aortic carotid bodies and that kind of stuff. The next C is talking about compliance. And whenever you hear compliance, what's the opposite of compliance? You talk about resistance. And resistance is two resistances: airway resistance and there's PVR. And then with compliance and resistance, what do you think of? Time constant, correct. But that's not the answer I wanted. I wanted work of breathing. Okay, so it's kind of all related. And then the other C is circulation. And what do I think of circulation? I think of VQ mismatch and so on. D, you can think of disease state. So when the question asks you about obesity, you talk about obesity hyperventilation syndrome or sleep apnea. You could also, if you forget the diaphragm for whatever reason, then you can link it to FRC and so on. All right, so in this question, we're going to answer A. A is anatomy, so vocal cord and upper airway swelling, mucosal friability due to the enlargements, capillary engorgements from increased circulatory volume, risk of trauma. And so avoid multiple attempts, avoid a nasopharyngeal, consider video laryngoscopy to increase the first pass success. Then we have breast enlargements, and that causes difficulty in inserting the laryngoscopy, and that's due to estrogen. Adequate positioning, consider short handle laryngoscope. Decreased FRC and increased VO2, rapid desaturation, what you do, the adequate pre-oxygenation RSI, and decreased loss of esophageal tone, increased intragastric pressure, delayed gastric emptying, increased gastric acid, aspiration risk, and you do an RSI. The other thing with the special populations, whenever you think of pregnancy, you have to think of estrogen and progesterone. Progesterone causes bronchodilation, estrogen causes increased VO2. And when you talk about obesity, you also think of hormones, not estrogen and progesterone, but you think of leptin. Anyway, it's just a quick rundown. And then B, we're talking about B, which is breathing, which is volume. So decrease FRC by 20% due to the gravity uterus displacing the diaphragm, worsen supine with anesthesia, decreases oxygen stores. So remember the oxygen stores we were talking about, combined with high VO2 and rapid desaturation, and you can easily include that in the airway. Increased VQ mismatch, where the closing capacity is greater than FRC, causing atelectasis and shunt. However, VQ mismatch offset by the increased cardiac output, recruitment, and distension of pulmonary vessels. So we do talk about VQ in its own thing, but with you can talk about it with the FRC. Now, when you're increasing VQ mismatch because the closing capacity is greater than FRC, you get atelectasis. Okay, so you get closing of the alveoli, but you also get shunt, and the reason you get shunt, and that causes VQ mismatch because you get so atelectasis causes shunt, which causes VQ mismatch. However, because you have an increased cardiac output, that shunt, which has been caused, is kind of offset by the increased cardiac output. So you get recruitment and distension and pulmonary. And I think that's mainly talking about because the dependent regions become collapsed, and so you get shunt where you have perfusion but no ventilation, and the non-dependent regions try and like kind of correspond to fix that low VQ. However, it's not in a normal person, but because they have increased cardiac output, then you actually have increased perfusion in the apex or the non-dependent areas. You also have increased PVR, and the reason you have increased PVR, but overall decrease due to increased cardiac output, recruitment, and distension of pulmonary vessels. So you have increased PVR because of the volumes are shifted from the FRC. It's obviously dropped, we said, by 20%. So it goes into the extra alveolar vessels. However, you overall have a reduced FRC, PVR, because you actually have increased cardiac output, which is a bit counterintuitive. Anyway, total lung capacity is reduced by 5%. Tidal volume is increased by 40%. And how do we remember that? We remember minute ventilation is tidal volume times respiratory rate. How much does the respiratory rate go up by? 10%. How much does the tidal volume go up by? 40%. Minute ventilation then goes up by 50%. It's like a nice mathematical kind of formula. And we include that in the B part. Okay, now we talk about compliance. So lung compliance, nil change. We don't actually know the reason for lung compliance. However, chest wall compliance is decreased because of the cephalad displacement of the diaphragm. Total respiratory compliance, therefore, overall decreases. Then, as I said, we talk about resistance. Airway resistance overall decrease because you got bronchodilation from progesterone, decreased airway resistance, but increases anatomical space, decreased FRC. What else do we talk about resistance? We talk about PVR. So again, it's overall decreased, even though the FRC shifts. Work of breathing, overall no increase. And then the VQ or the gas exchange, so increase in VO2 and VCO2 due to increased metabolic. So the HbCO2 left shift due to decreased PaC2, but right shift due to increased 2,3 DPG. So because you get hyperventilation, you get a decrease in left shifts, but then it right shifts because of the 2,3 DPG. And then what's important is the controlled ventilation. So that's a big one. So chemoreceptor sensitivity increases, and it increases because PaCO2 decreases due to progesterone left shift. So the sensitivity actually increases in respiratory rate by 10%, tidal volume by 40%, minute ventilation by 50% in the third trimester. Further increase in labor during contraction and pain, and increased VO2, so oxygen consumption with uterine contraction with transient hypoventilation in between contractions due to the hypocapnia from the hyperventilation. Then you have PaO2. So the PaO2, due to an increase in minute ventilation, it decreases the PaCO2, and that causes an increase in alveolar oxygen as per the age, the alveolar gas equation. So if you take an ABG, and that leads us to an ABG, you get fully compensated respiratory alkalosis, decreased PaCO2 due to the increased minute ventilation, but you get an increased AO2 as per the age. Increased ventilation. So higher normal pH and low HCO3 due to the renal compensation for the decreased PaCO2. So the pH is 7.45, the PaCO2 is 30 millimeters of mercury, and the PaO2 is 105, which is quite high, and the HCO3 is 20, with a base deficit of -2 to 3. There was a question about respiratory alkalosis in pregnancy. And just to close it all off, the main thing I would probably start with this is that in pregnancy you have an increased metabolic demand, increased throughout pregnancy, 20% higher at term, maximum in labor. Endocrine changes, where you get estrogen, which causes nutrient growth, you get progesterone, which causes nutrient storage, and also bronchodilation. You get relaxin, which causes relaxin of the ligaments. You also have HCG, which maintains progesterone secretion by the corpus luteum in early pregnancy, and you have the HPL, which is an anti-insulin effect in the mother to provide nutrients to the fetus. And then number 2 or 3, whatever, is mechanical effects of the gravid uterus, which is the FRC. Uteroplacental circulation increased from 150 liters per minute to 750. That reminds us of cerebral blood flow. But the uteroplacental is from 150 to 750. So again, you talk about increased metabolic demand, you talk about the endocrine changes, you talk about the FRC, gravity uterus, and then you go through ABC.